Good morning to all the early risers. This month is full of nephrology, and of course, we started with the Rambam Summit. You heard about kidney transplantation, and we continue this month of nephrology by an invited lecture. So on behalf of the Rambam family, I am delighted to welcome our distinguished guest speaker for this week Rambam Hospital Wide Grand Round, Professor Ravi Thadhani. Professor Thadhani completed his MD studies at the University of Pennsylvania in Philadelphia in 1991, and his MPH studies at Harvard's School of Public Health in 1997. All of his clinical training were performed at the Mass General, both residency and fellowship in nephrology, and currently he's the Chief of Nephrology at the Mass General, Executive Director of the Clinical Trials Office at Partners Healthcare. He's a Professor of Medicine at Harvard Medical School, and most recently, he's also a clinical consultant for the Center for Environmental Health Services at the MIT. And as you will also witness today, he's an eloquent speaker. Professor Thadhani received numerous awards. He has a strong track record of publications and grant support. He published more than 250 papers in leading journals, including the New England Journal of Medicine, Journal of the American Medical Association, The Lancet, PNAS, Circulation, Journal of the American Society of Nephrology, Kidney International, and many more. He's an inducted member into the American Society of Clinical Investigation, the American Epidemiology Society, and the Association of American Physicians. Dr. Thadhani has mentored several fellows and junior faculty members, many of whom are on faculty at leading institutions in the US, and we also hosted Miles Wolf, who's also your trainee. Dr. Thadhani is a world expert in the field of vitamin D metabolism. He has performed several hypothesis-generating observational studies suggesting that therapy with activated vitamin D sterols is associated with improved survival among patients with renal failure. Thereafter, he initiated the PRIMO study, the first multi-center, multinational randomized trial in nephrology to test the hypothesis that active vitamin D therapy favorably affect cardiac hypertrophy and diastolic dysfunction in CKD patients. His work has been recognized and incorporated into the current international clinical practice guidelines, including in Rambam, of course. In collaboration with basic scientists, Professor Thadhani, other research focused on understanding and treating disorders of pregnancy, which will be the theme of his talk today, entitled Pre-eclampsia, an example of a translational medicine. So, Ravi, thank you again for visiting us. And it's an honor, and the podium is yours, please.
Good morning. It's an absolute honor to be here this morning. Usually we put our recognitions and thanks at the end, but I'm going to start with that, because over the last few days, I've had the great honor and pleasure of not only being able to visit this incredible country, but this incredible institution. And most, of course, importantly, are the amazing people, including Dr. Farid and Dr. Asadi and, of course, Dr. Skretsky. I would say most importantly, Dana, but I have to be careful. You have a very special place here, and it's really an honor to be here, and most importantly, to be able to interact with scholars at this institution and learn from leaders, not just as Carl is in nephrology, but also in medicine. And it's an absolute delight, and I look forward to bringing my family back on occasion. I've had some help with some Hebrew, so I apologize. I won't be able to speak, but I have some slides that allow one to easily translate. There's always a danger if you give somebody the chance to put some other languages in your slides because you're not sure what they're going to put in. But that said, I had it checked by Dana and I received the approval, so I'll proceed. I'm very interested in pre-eclampsia as a kidney specialist, primarily because pre-eclampsia is a disorder that affects the kidney. It's a systemic disorder, as we'll talk about. We'll talk about who gets this condition, the signs and symptoms of this condition, and most importantly, what my colleagues and I have been very interested in is how do we develop diagnostics and therapeutics in this space. By way of background, of course, in medicine, we don't often interact with our obstetrical and MFM colleagues. So just to remind us in terms of the definition of the disease. And as we talked about yesterday during the incredible research conferences that we had, pre-eclampsia has many different clinical definitions. In today's society, there are over 7 clinical definitions of this condition. What we do know is that women have significant morbidity and mortality from this condition. It's a condition associated with elevated blood pressure and proteinuria. It's a condition that is systemic, and as you can imagine, you can look at the liver, you can look at the brain, and find abnormalities there. There are subsets of the condition, for example, the HELP syndrome, which I won't speak about this morning, but suffice it to say there's a spectrum of mild to severe. The HELP syndrome would fall in the category of the most severe. The incidence of this condition worldwide ranges between 2-4% all the way to 8-9%. And my understanding is that is no different than in this fine institution. It's a disorder that affects women of all ages, all races, all ethnicities. It affects women who receive IVF. It affects women who have chronic kidney disease, as we'll talk about in terms of the risk factors. And importantly, it is mild for the most part in 75% of women, but it is quite severe as a disorder, leading to actual significant morbidity and mortality in about 25% of women. Now, one debate that comes up in this particular condition is the definition of the disease. As you can imagine, if there are over 7 or 8 different definitions around the world, and you just minorly change the definition, then necessarily you change the incidence of the condition, you change who gets treated, who gets screened, who gets managed, who delivers early versus who delivers late, who receives a cesarean section versus who does not. And so minor changes in the definition of the disease and the criteria for defining women with this condition changes the outcome. Pre-eclampsia represents the number 3 or 2 cause of why women die in pregnancy. Fortunately, death in pregnancy is not common, but if you look worldwide, bleeding and embolism are perhaps causes number 1 and 2, but unquestionably, pre-eclampsia in many different parts of the world, including the United States, represents the 3rd, at least, cause of why women die in pregnancy, an incredibly devastating, of course, disorder. There are many consequences of this condition. There are fetal consequences of this condition. There are maternal consequences of this condition. And to remind an internal medicine audience that the fetal consequences of this condition most often result from early delivery. And as a result of that, this baby then born has consequences to him or her throughout their lives. So while we look at the immediate consequences, namely the neonatal ICU care stay, the requirement for oxygenation, potential risk for sepsis in the hospital, the consequences last, of course, for a lifetime for a baby that is born prematurely. I highlight these consequences because if one imagines doing a clinical trial in this space, these are the kinds of outcomes that will be looked at, not only, of course, for efficacy, but most importantly, for safety. One can go to the internet and find the signs and symptoms of this condition, and they're quite varied. A woman might come in at her prenatal visit and complain of a mild headache or mild right upper quadrant pain, or for that matter, have just a bit of swelling, only to find that her blood pressure is high and has some protein in her urine. The manifestations are quite protean, and it highlights the fact that this is a systemic disorder. The end organ damage that occurs affects many different organ systems, including the kidney. Liver function abnormalities and liver failure, while uncommon, certainly occur. Cerebral edema, visual changes, significant pedal edema, and again, the systemic condition, hypertension, proteinuria, all as part of this larger spectrum. From a nephrology standpoint, we think of the relationship between the kidney and the placenta, not perhaps a common interaction one can imagine, but to highlight the fact that in normal pregnancy, glomerular filtration rate has to go up. It goes up by 30 or 40%. It reaches a peak at approximately 20 weeks of gestation. What's fascinating about this interaction between the kidney and the placenta is if you take a woman that's received a transplanted kidney and ask what happens to her glomerular filtration rate, she will go from a GFR of 80 to 90 up to 120 to 150, even with a transplanted kidney, reminding us that there is something released from the placenta or some communication from the placenta, probably some factors released from the placenta, that drives the kidney to increase its GFR, to accommodate the increase in the intravascular volume, the changes in blood pressure, the changes in systemic vascular resistance that are all necessary in order to have a healthy pregnancy. So what do we think about this disease? We know from our past experience that this is a disease that causes significant morbidity and mortality, with an incidence, of course, of 4 to 5%, acknowledging that while most women will have mild pre-eclampsia, it's those women that have severe pre-eclampsia, and most especially preterm pre-eclampsia, that we're interested in diagnosing early and potentially developing a therapy. That's our current state of affairs today. We, during prenatal visits, screen with blood pressure and dipstick for protein. The clinical definition, as I said, is quite varied. But we think, and others, of course, have worked extensively in this area to argue that we need to improve our definition. And with improved definition in this era, of course, of almost personalized medicine, we can develop specific and targeted treatments. Now, just as a short tangent, when you think about women who present in pregnancy with preeclampsia, when do they show up to an internist's office? They show up years later. They show up 30 years later. The consequences, of course, are many. They're usually vascular in nature, with an increased risk of stroke, cardiovascular disease. Women with a history of preeclampsia have a 40-fold increased risk of requiring a kidney biopsy at some point in their life. They're also at increased risk of requiring dialysis at some point in their life. The question is, of course, why, and what are the mechanisms involved in this progression from a disorder that happens in pregnancy, which then, for the most part, remains quiet after pregnancy, only to manifest itself as significant vascular end organ disease many years, of course, later. Dr. Skoretsky, in his classic sort of piercing way, asked me the question a few days ago, which is, why is it that in pregnancy you get this kidney disorder and thereafter you find end-stage renal disease? And while it isn't entirely clear, there's no question that while women might be predisposed to this condition, perhaps going into pregnancy with high blood pressure and proteinuria, diabetes perhaps, the pregnancy itself incites some injury, and that injury then manifests later on after subsequent injury, whether it's progression of blood pressure, because these women are at increased risk of chronic hypertension, or other targets of injury, for example, like diabetes, only to start with a normal kidney, injury in pregnancy, and then later on with sclerosis or scar manifesting itself again 20 or 30 years later. That's our best understanding. And the pieces that link this progression, of course, are only now beginning to make some sense to us. From a large-scale epidemiologic standpoint, one can ask who is at increased risk of this condition, and one can highlight the risk factors for this condition. And while I won't go through these risk factors, I'll just highlight the fact that majority of women, of course, other than being pregnant and perhaps being their first pregnancy, really have no risk factors that one can highlight to explain why she develops this condition. So there must be other factors, other mediators, other ideas as to why women get this condition. So we have spent about 15 years asking the question, should we screen women for this condition, other than with blood pressure and dipstick proteinuria? What are the benefits of screening? If you don't have a treatment, why would you screen? A targeted treatment, that is. The only treatment we have to date, of course, is delivery, the major decision that an obstetrician, MFM doctor, in conjunction with consultants, perhaps a nephrologist, has to make is, should you deliver the mother? And so the question comes up, is there a role, for example, of screening? Well, we screen, of course, if we can offer a treatment. We have to be careful about the screening criteria for any diagnostic test, sensitivity, specificity, and the standard characteristics of any test. And making sure, especially when you're dealing with two lives, both mother and baby, that the decision, of course, is a right one. In the early stages, of course, of pregnancy, you can imagine a screening test that looks at risk stratification. As you get closer to the disease, pre-eclampsia typically happens after 20 weeks of gestation, you think about diagnosing or immediately predicting the condition. And then at the time of the disease, when she has the full-blown manifestations of the condition, a test intervening at that point, for example, might give you a sense of the outcome or prognostication. So pre-eclampsia happens after 20 weeks of gestation. And in today's world where diagnostic testing is going, you will see a more of an interest in first trimester screening, because that perhaps is the time when therapies can be introduced to prevent the condition, of course, from occurring. Now, that's not to say that when a woman has a suspicion of preeclampsia, when she shows up with slightly elevated blood pressure or slightly elevated proteinuria, that you don't do a test at that time, because maybe a test at that time might help you decide if she is imminently going to develop preeclampsia. So this is a disease where understanding the pathogenesis has been a problem, and as a result of that problem, we don't have good diagnostic tests and, of course, no good therapies. I'll go back, and the obstetricians know this history all too well, to 1983, when hypotheses were put forward as to what the etiology of preeclampsia was, or is at the time. And one of the hypotheses put forward in 1983 is that this disorder, which has remained elusive for decades, if not centuries, was due to a microorganism. And so in a paper in 1983 in one of the obstetrics journals, this picture was shown and highlighted that it was an organism, parasite maybe, bacteria, that was responsible for preeclampsia. Now, of course, 1983 was an interesting year, other than the fact that it was the same year I graduated from high school, which dates me, of course. But it was the same year that Marshall and Warren published a landmark article in The Lancet that said that microorganisms were responsible for gastric and gastritis and peptic ulcer disease. So the unidentified curved bacilli turned out, of course, to be Helicobacter pylori. And in 1983, at the beginning of the year, this was published, and every illness as you can imagine, that had remained unexplained, including preeclampsia, went through an exercise of asking, could that illness be due to an infectious organism? And preeclampsia, of course, was one of them. Now, we know, of course, the fate of both of these observations, right? The fate of this observation, Warren and Marshall in Perth received the Nobel Prize in Medicine. The fate of this observation was that this was found due to an artifact from talc and surgical contamination. And that's essentially the history of preeclampsia with regards to different hypotheses being put forward and changing the landscape of our understanding. So, with colleagues that I've been working with at the Beth Israel Hospital in Boston, we have put forward a hypothesis as to an etiology of this condition. And we'll talk about that in the next few minutes. And based on that, we've asked the question, can we develop diagnostic tests to help the clinician with much more precision decide if this is preeclampsia or this is lupus, preeclampsia or chronic hypertension, preeclampsia or diabetes? Because what you do with that diagnosis is determined on how you define it. If it's preeclampsia, you go in one direction. If it's lupus, you go in a different direction. So we've asked the question based on our, or at least better understanding of the pathophysiology and the perhaps better understanding of mechanisms. In addition to developing a diagnostic test, of course, one can ask the question, can you use this better understanding to develop a therapy? So from a cartoon standpoint, it's always better to show cartoons early in the morning, the hypothesis goes as follows. That is, there is a soluble receptor that circulates in blood. The soluble receptor has the same ligand-binding domain as the membrane-bound receptor. It's the same receptor, except this is bound to the membrane and this circulates. Both the soluble and the membrane-bound receptor bind ligands, VEGF and PLGF in this case. And preeclampsia, we think, is characterized by an imbalance such that there is too much of this and not enough of this, creating this imbalance, and as a result, not enough signaling at the membrane-bound receptor. If you look at the kidney and ask what is going on with regards to proteinuria and kidney injury, one can think of it, again in a cartoon fashion, as follows, which is there is fenestrated endothelium, that is those endothelial cells that have windows. These endothelial cells have receptors, the VEGF or the FLT receptor, same thing. And these receptors are bathed by VEGF made by podocytes. Preeclampsia is a condition when there is an interruption of that VEGF signaling, such that in the absence of VEGF signaling to these receptors on endothelial cells, these endothelial cells become swollen and lose their fenestrae. They lose those small apertures, those windows between them. What this means is that any organ bed that is dependent on VEGF signaling in the setting of preeclampsia demonstrates injury. Any organ bed that has fenestrated endothelium has injury in the setting of preeclampsia. So if you do a kidney biopsy in a woman with preeclampsia, you find swollen endothelial cells. Those endothelial cells are highly dependent on VEGF signaling. If you look and could do a biopsy of the choroid plexus in the brain of a woman with preeclampsia, for example, when she complains of visual changes or a headache, those endothelial cells are swollen and have lost their fenestrae. Their VEGF-dependent and soluble FLT interrupts that cascade. The same thing goes in the adrenal gland, the same thing goes in the heart, and so forth and so forth. Fenestrated endothelium, highly dependent on VEGF signaling. So when we first came up with this hypothesis, one of the early studies we did with the late Richard Levine from the NIH was ask sequentially over time, if we followed pregnant women as they got closer to preeclampsia, could we use diagnostic tests to predict who would get the condition? So this was one of the early papers we published. In red are women who go on to get preeclampsia, and in blue are women that don't go on to get preeclampsia. And importantly, you see two things from this curve. One is that the curves begin to separate after 20 to 25 weeks of gestation. The diagnosis of preeclampsia is often after this time period. And two, normal pregnancy is characterized by an increase of soluble FLT, which tells you that this is a normal protein in pregnancy and probably has important biologic roles to play. Now, this becomes important in developing a therapy because you don't want to interrupt this cascade, or at least this progression. However, it's the early and the much elevated rise in soluble FLT that characterizes preeclampsia. Now, from the back of the room, you're probably saying to yourself, this does not look like much of a separation. And I'll just tell you a very quick story of this point. We used assays made by a company called R&D Systems. We used ELISA assays in our laboratories to measure soluble FLT. R&D Systems actually had no idea what the purpose of the assay was when they developed the assay years before when we came. And in the classic fashion of developing ELISA assays, the company looked at samples from many different populations. And they wanted to put out assays because that was their business. Their business was to put out ELISA assays. And when they received samples from pregnant patients, the levels of soluble FLT in those samples were tenfold higher than in the normal population. Now, of course, they said, we can't create an assay that has such a large dynamic range and have such a large change from normal to abnormal. And frankly, we don't know what it means. So we're going to add reagents to this assay to mute the samples so that all of them fall into a very narrow range. In other words, what you're seeing here are assays that suppress the significant elevation in pregnancy. We published a correction to this paper after taking out those reagents. And when you look at the difference between disease and non-disease, you find a tenfold difference, not a twofold difference. And that gets into the category of now being able to use this as a diagnostic test. Now, the counterpart for this particular protein, PLGF, placental growth factor made by the placenta, binds to the soluble FLT receptor, is low in preeclampsia. And when you look at the natural changes of PLGF in red are women who go on to get preeclampsia, in blue, normal. And you see it's much lower and it starts earlier. Now, I should remind you that these curves are all levels in maternal blood well before signs and symptoms. These women are asymptomatic when we've checked these levels. Here, at the end, this black line represents the levels when symptoms are present. And you see that PLGF levels are incredibly low. And just going back to soluble FLT levels at the time of signs and symptoms are incredibly high. So this was over 10 years ago. And let's fast forward now, 12 years ahead of that, where in the New England Journal just last year, a group independent of us looked at the rule-out characteristics of the ratio of soluble FLT over PLGF, highlighting that if a woman comes in and has a suspicion for preeclampsia, if you check these markers, and the ratio in this case is less than 38, there is a less than 1% or about a 1% chance that she will go on to get the condition. In other words, allowing the obstetrician, the MFM doctor, to exclude the condition. This test is actually quite specific because, for example, the standard conundrum for a nephrologist is lupus exacerbation in pregnancy versus preeclampsia, in which case lupus exacerbation would not change these markers, however, preeclampsia would. Again, very specific for this condition. So as a rule-out test to decide who to send home and who not to send home, or who to send to a tertiary care center and who not to, this seems to be quite effective. We've been very interested not just in the rule-out capability of these assays, but more importantly, the rule-in capabilities of these assays. That is, who do I define as going on to getting the condition so that I can develop a treatment for this condition? And so while the rule-out cutoff is 38, the rule-in cutoff is somewhere in the high or mid-80s. And those women that come in with a suspicion of preeclampsia, who have ratios above 85, will literally deliver, independent of what we do, of course, will literally deliver within a week or two. So the goal of therapy, of course, is to prolong gestation, to allow a woman, not when she comes in at 37 weeks, in which case delivery is appropriate, but when she comes in at 27 weeks, when there's hesitation to deliver her because of the consequences of premature delivery, to then take that woman and extend pregnancy in a safe and effective manner. Now, the major challenge when we go out and ask, is this an important area to focus on, is if we have methods to diagnose this condition before signs and symptoms, does that also mean that we have an earlier treatment? Because what we don't want to do is unnecessarily create anxiety to the mother, to the caregiver, to say you are at risk of a condition, but unfortunately there is nothing we can do about that. Because of course not every woman is going to go on to get the condition, and the decision for delivery is not going to be based on a blood test. The decision for delivery is going to be a clinical decision based on the health and the status of the mother and the baby. So in the last few minutes, I'll just share with you what we've tried to do in terms of therapy. We now have a diagnostic test. It's used in different parts in Europe. It's not approved by the FDA in the United States. We've asked the question, and the FDA has asked us the question, why do we need a diagnostic test when we don't have a therapy? It's a chicken and the egg question because we're trying to develop a therapy. We need the diagnostic test to develop the therapy. And of course, we go back and forth in that debate. But just in the last few minutes, if you don't mind sharing with me how we've approached targeting this particular protein to develop a therapy, the therapy being is if we can lower those levels, we can reduce the signs and symptoms of the condition. Why do I say that? Because the animal models tell us that if you take this protein and give it to an animal, the animal develops hypertension and proteinuria. If you then interrupt the pathway, as I'll show you, in an animal model, hypertension gets better, proteinuria gets better, and so forth. And of course, our goal is to replicate that in the human model. So, you can diagnose a woman now early, before signs and symptoms, or even at the time of disease, and target a particular protein. And my suspicion is going to be that in the next 10 years, this may not and probably will not be the only target. There will certainly be other targets. But at least, given the epidemiology and the animal experimental data that we have to date, it is a reasonable approach for a condition that, in our opinion, has been largely ignored by way of therapy. So, one way to target this condition, of course, is to give back more of the good. The good in this case being VEGF or PLGF. And if you administer VEGF or PLGF to a pregnant baboon, for example, you can flood the system such that these agents bind the soluble receptor, which is elevated in pre-eclampsia, but importantly, bind the membrane-bound receptor and cause signaling, which is what you're trying to achieve. So, over the last 10 years, we have given VEGF back to pregnant baboons, the baboon model being the model that we've used to look at and test different reagents for therapy. We've shown that you can give back VEGF and reduce blood pressure, you can reduce proteinuria, you can reduce soluble FLT, you can reduce end organ damage. The problem with many of these agents is that when you give a foreign agent to a pregnant patient, you have to not only look at safety for the mother, you have to look at safety and toxicity, of course, for the baby. Because these agents undoubtedly cross the placenta. And to make a long story short, when we gave VEGF back to pregnant baboons, while it reduced the mother's blood pressure, VEGF crossed the placenta and led to fetal complications. We've also given back PLGF for a variety of reasons, and I won't go through all the details. And it seems to be much safer, but it requires us, of course, to do extensive amount of safety studies to make sure that if and when we administer this to pregnant women, we're not causing harm to the baby. So that's one approach that we've tried, and maybe in the future we'll have a subcutaneous injection of PLGF. Another approach, of course, of this condition, if the protein is elevated, is to give an antibody against the protein to reduce its levels. Giving an antibody is a very standard biologic approach, or at least a standard interventional approach for many diseases we give and treat today. It makes perfect sense. We can manufacture humanized antibodies. They're non-antigenic. We can administer them easily. There's an FDA approval pathway a European approval pathway, worldwide approval pathway for monoclonal antibodies. The problem, of course, of giving an antibody is that the antibody crosses the placenta very effectively. The placenta has receptors that take antibodies from maternal circulation and transfers them to the fetal circulation. And that is how a mother confers to the baby immunity from many different diseases. So an antibody makes great sense. It allows us to be very specific in our target. But once again, unlike in developing other therapeutic agents for other diseases, when you're dealing with two lives, you have to worry about the toxicity to the fetus. And antibodies very efficiently cross the placenta and will and can bind the VEGF or the FLT receptor on endothelial cells in the fetus and necessarily lead to complications. Finally, after having abandoned that approach, we've asked the question from a nephrology standpoint, a specialty that has tremendous experience in taking things out, namely dialysis. Can we just take this protein out? Can we take a protein out that circulates in maternal blood that is responsible for the maternal complications, the hypertension, the proteinuria, the cerebral edema, taking this protein out of maternal circulation and being able to titrate those levels so that we don't take out too much, because remember, this is a protein, a normal protein of pregnancy, but allowing us to reduce levels so that her signs and symptoms don't get worse, and allowing the obstetrician or the MFM doctor to keep her or allow her to remain pregnant, so that perhaps she goes from 27 weeks to 29 weeks to 32 weeks, reducing, of course, the complications for the baby. And we've done that. We have used cartridges using a variety of properties. Those properties include charges, because soluble FLT turns out to have a very strong positive charge with an isoelectric point of 10. Imagine taking maternal blood out, running that blood, cleansing that blood, if you will, of whatever is positive by using a negatively charged cartridge, negative beads, and then once cleaned of soluble FLT, returning that blood back to pregnant patients. And we've done that in now a number of patients as a proof of concept. But that's a non-specific way of removing a protein. The good news is, if there's a side effect, which could be, for example, a blood pressure reduction, you can turn the machine off. The goal of these kinds of therapies, of course, again, to remind an internal medicine audience, is to take a woman that presents at 26 or 28 weeks or even earlier, where the complications for the fetus, respiratory distress, sepsis, and so forth, are incredibly high, and to march her forward by 1, 2, 3, 4, 5 weeks, and in doing so, leading to an almost exponential decay of all of these risks to get her closer to term. Because it's this early delivery, this premature delivery, that leads to the complications not only in the hospital, the neonatal ICU care stay in the hospital, but the long-term consequences, of course, for the baby. The conundrum is that you want to keep her pregnant so that the baby can become much more mature if she presents here. But on the other hand, this is a disease, as I'm often reminded of, that within 24 to 48 hours, a woman can go from being completely asymptomatic to developing a seizure, renal failure, kidney failure, and dying. And that's the challenge with this condition. When we first started our studies, and having now developed diagnostic tests, we went to many different centers, and we asked if we took women with very severe preeclampsia and did not treat them, what happened to them in terms of the dates of their delivery? And this is just an example of levels of soluble FLT in women that we did not treat from the same centers where we developed the treatment, making sure they met the entry criteria of our trial, or our study, our single-arm study in this case, that is severe preterm preeclampsia, the standard definition, and the obstetrician validating that. And preterm is the key phrase here, or the key component here, because if it was term, you would deliver her. It's the preterm component that creates this battle of delivering versus not delivering. Now, the normal levels of soluble FLT in pregnancy at least at 27 or 28 weeks, is about 2,000 picograms. The normal levels, well, not normal, but the levels of pre-eclampsia are 20,000 picograms. So there's a 5 or 10-fold difference in levels. And this is what happens when women don't get treated. And more importantly, what you see is they all deliver within 4, 6, 7 days. And that's the benchmark of developing a treatment. So we went to centers, we looked at machines, we asked the question which machines would be safe, how could we remove the blood, the flow rates of the blood, the kinds of anticoagulation that we could use, peripheral access, not central access, what the duration was, how long can we actually ask a woman to stay put comfortably on her back, and went through the regulatory process, training process, and now have treated almost 20 women with this kind of intervention. And here is an example of some of the women that we treated. And of course, in the standard fashion, I'm showing you the best data. There's a lot of data that we did quite early to try to learn this. But here's a woman that came in at 28 or 29 weeks. The levels are 13, 14,000. Again, the normal levels being 3 or 4,000, if not lower. The dashed lines represent the days of treatment. And you see that we wait for her levels to go up. We then, what's called apheresis. We do a pheresis procedure to remove soluble fluid levels. We wait for a few more days, wait for those levels to come down. And then we stop treating her because we have to understand and appreciate the safety of these kinds of interventions. And necessarily she delivers at day 15. The way we did these therapies is we first treated for 15 minutes, then 30 minutes, then 1 hour, 1 hour and a half, 2 hours, and so forth, all the while monitoring the baby and the mother, making sure the therapy was safe. Here's a woman that we treated 4 times, again, showing that every time we treated her, we could reduce her levels. And she went on, again, presenting at 29 weeks of gestation, remaining pregnant, again, no exacerbation of her signs and symptoms, obstetrician making the decision for delivery, she delivering 23 days after presentation. What was most interesting in these kinds of examples is that almost every woman we treated, whenever we reduced soluble fluid levels, just going back to the cartoon I showed you earlier in this talk, what's happening in the kidney is there's a reduction in proteinuria at the same time, reminding, of course, ourselves that hypertension and proteinuria are the classic definitions of this particular condition. Again, in the untreated state, you can imagine a woman going from 1 gram to 10 grams of protein, again, twisting the arm of the obstetrician to deliver her. And finally, blood pressure changes in these women. We had to be very careful because if we lowered blood pressure too much, we would reduce blood flow to the placenta. And so we would titrate the volume and give back volume, titrate the blood pressures, the blood pressure medications, to necessarily not significantly change blood pressure. We've gone through various iterations of machines, improving the clearance, improving the flow rates, reducing activation of complement, reducing activation of cytokines, working with various different companies, with a focus on developing a cartridge that has an antibody on it that specifically removes the protein of interest, which we're now developing and have now treated with an antibody-based column women in the United Kingdom. Of course, if this was a nephrology meeting, I'd go through all of these pumps and so forth, and they would generate a lot of excitement, but I doubt this audience would be interested in something like that. And so finally, what are the outcomes of these kinds of interventions? From the back of the room, you look at the red lines, those women that we've treated, and the blue lines, the women we did not treat. And while we didn't do a randomized trial, you get the sense that in general there's a prolongation of women that we treated. And importantly, when you look at estimated fetal weights, because it's one thing to prolong pregnancy, it's another thing to allow the baby to grow in utero, which is a key component, that there is an increase in weight while pregnancy is being prolonged, necessarily reducing the side effect profile and, more importantly, the complications if she then has to deliver, fortunately, 4 weeks, for example, after we develop an intervention. So I'll stop there. I think it'll give us some time for some questions and highlight a few last remaining items. One is that we had to pay a lot of attention to the biology of this condition. It had and continues to remain elusive, and while we haven't uncovered all the biologic mechanisms, we've uncovered a pathway. With that pathway and developing and generating enough interest and, more importantly, supportive information, both animal experimental and clinical, developing a diagnostic test at the time at least where we don't have a therapy, but a diagnostic test that allows us to develop a therapy by targeting the right population. The diagnostic test allowing us to determine the dose, the frequency, and importantly, which women not to treat, to make sure that we keep the balance of risk and safety and benefit, of course, intact. And finally, as a first effort, proof of principle concept, trying to validate a pathway using therapies that nephrologists are familiar with, which is removal. And if we can do that in a non-specific way, which is what we've done using charge-based columns, we can now do that with an antibody-based column and validate a pathway. And once the pathway is validated as an appropriate target, developing biologic treatments. And one day, I hope, 10 years from now, for example, having a multi-pronged approach, not unlike what we have in many medical conditions, with a biologic and a device. Now, all of what I've shared with you today, of course, would not have been possible without the many people, and especially the basic science colleague I have at the Beth Israel in Boston. I want to stop and, again, leave time for questions, but once again, thank everyone for the hospitality and the incredible opportunity to visit here. Thank you.